Hi, I'm Chris Ketzley, Executive Director here at the Association of Towns. Talk of the Towns podcast is a production of the New York State Association of Towns and strives to bring the voices from across New York to talk about all things towns. If you're interested in participating as a guest, please email us at info@nytowns.org. The views and opinions expressed by podcast guests are of their own and do not necessarily reflect the views, positions, or policies of the New York State Association of Towns. Good afternoon and welcome back to another edition of Talk of the Towns. We have a great guest for you here today, and we're going to talk about something very important to our members, very important to all New Yorkers really, but certainly in context to town officials, town employees, and town budgets. We're going to talk about the state of the health insurance market here in New York. And I think you're going to find it very interesting and really learn a little bit about what's driving it and hopefully what we might be able to do to try to stop it a little bit. We've had other podcasts where we talk about strategies to deploy. This podcast, we're going to delve more into what it is that is driving those rate increases. And so you're gonna enjoy it. Before we get to it, I do want to just remind you, we always ask you to hit like, share, and subscribe on any of the platforms, Spotify, Apple, YouTube, however you watch or listen. Make sure you're sharing it with other town officials in particular, but any of your friends who might be interested in local government and all things towns. And so let's dive right into it. I want to welcome to the show Lev Ginsberg from Hinman Straub. You are the Executive Director of NYSCOP.
The New York Conference of Blue Cross and, the New York Conference of Blue Cross and Blue Shield Plans.
Did I say it right?
NYSCOP.
NYSCOP, okay.
Conference of Plans.
Got it.
I'll answer to anything.
All right. Well, welcome, and thank you for being here.
Thanks, Chris. Thanks for having me.
I started talking a little bit, and for our, common podcast listener or follower, it's not going to be unusual for them to hear me talk a little bit about some of the issues that are facing towns. And one of them in particular is health insurance. And, we were chatting a little bit a minute ago before we started that over the past 10 years, it really has skyrocketed and started to compound on each other, the health insurance premium increases. When you look at individual market, I looked this up, over the past 10 years, since 2015 anyway, individual market has increased by 113%. Small group by 88%. NYSHIP, which many of our members are in, 57%. That's 2.5 times the tax cap, allowable tax cap. So when you put that in play, that tax cap could have only gone up 22% over the past 10 years. And most, I think, stark is that the CPI only went up about 29% in that same period. And so, I guess we'll start with, let's dive right into, this is unsustainable, but what is causing the health insurance premiums to skyrocket like this?
So, you're absolutely correct. The numbers are large and they're unsustainable. Really, the focus of what I do with the Blue Cross and Blue Shield plans in New York is constantly fight for affordability in healthcare. Looking for ways to keep premiums down rather than premiums endlessly increasing. And for obvious reasons, we want our customers, we want our enrollees to be able to afford quality care at an affordable price. And so we're sort of laser focused on these exact issues. It's easy to, and we'll get to some of this later, I'm sure, but it's very easy to sort of look at health insurers and health insurance as a desire to have more money come in. But the reality is that health insurers, especially the Blue Cross and Blue Shield plans in New York, are spending 93 cents on every dollar on healthcare itself. So that's leaving a very little bit for overhead, not much more than really a handful of percentage points. So when the health costs keep going, that pressure is even greater. So we spend a lot of time thinking about the issues of premiums. So cost drivers over the last many years. So the health insurance industry, or the health insurance costs, are essentially a mirror of healthcare costs. So whenever healthcare costs go up, your premiums essentially go up. Sometimes they are suppressed by the Department of Financial Services. Usually that is not a natural suppression. Usually it's something just to keep the rates lower than they should. And we see plans actually running in the red. We've seen it across New York where plans are, especially the not-for-profit plans in New York, are actually spending more on healthcare than they're taking in premium, especially on these kinds of small group rates that we're talking about. So leading cost drivers. Over the last many years, there have been amazing changes in healthcare. And so there's good and there's bad. And some of it is just reality, and some of it is things that we need to really take a hard and fast look at. So if you went back 50 or 60 years and you had someone with heart problems or something, they would be given nitroglycerin and sort of sent on their way to rest. We know that today, thank goodness, we can do all kinds of amazing things, whether it's surgeries or medications, and every day there's some new leading edge technology or pharmaceutical that helps us. These come at a tremendous price. So when you look at that's sort of a natural sort of inflation of healthcare. Some of the stuff is priced in a way that is absurd. So we need to take a real look at that. And some of it is just a natural sort of increase. That what used to cost very little, now we can treat someone much better, so it costs a lot. So that's one thing. But so pharmaceutical costs, let's sort of set that aside for a few moments because there's a lot of things going on there. But certainly that's a huge thing. Over the last few years, GLP-1s have led the charge on expense. People are using them for weight loss. They're using them for diabetes. And the proliferation of this use has been massive. And I'm sure that your members have seen it across their employees. So there's all sorts of stuff going on there. So we'll set that aside for a moment. The other sort of major thing that's going on outside of the legislature, and we'll get there in a moment.
They always find their way into making sure a problem is made worse.
I'm not going to endorse the exact language that you used, but what we saw this legislative session did not give me a lot of comfort in their interest in making things better when it comes to health insurance and healthcare costs. But the consolidation of hospital systems, and depending on membership, wherever you are, sort of in the state, downstate, upstate, there are some differences, but there's been such massive consolidation of hospital systems. Here in the capital region, we have two major players. We've seen them sort of gobble up physicians, physician practices, and testing facilities and MRI facilities and all of that. In the city, we have 6 hospital systems in the state of New York that have the majority of income in the whole state. So when that happens, when we started to allow consolidation to occur, we were sold sort of a bill of goods that consolidation will lead to lower cost. There'll be greater use of economies of scale and all of that. But what we've really seen is that this consolidation has led to these monopolies or duopolies in any given area, and you end up having to negotiate with the only game in town. When you have to negotiate with the only game in town, prices go up every time. So we have seen somewhere in the neighborhood of 22% increases without any increase in the quality of healthcare in communities where there's been massive consolidation. So that has put an enormous amount of pressure on cost in a lot of different ways, and we can sort of get into very specifics on that if you'd like as we sort of go on. But basically that is a major cost driver, and there's 100 different reasons why it costs more money, and there's several different ways that we could approach making it a bit better. One of the things that you and I have spoken about, and now we're sort of shifting over to the legislature for a moment, is mandates on health insurance. So mandates run the gamut from what you have to pay for a procedure, or what procedure you have to cover, or what sort of new novel treatment we have to cover. And each time, each one of these comes at a cost. And New York has well over 70 mandates at this point on private insurance. And that probably at this point now leads the nation. We might be number 1 in mandates on private insurance. And this legislative session that just ended last week passed in the last week, I believe 9 would be my count, 9 new mandates. And and not a lot of relief. And we certainly had a lot of ideas on how we can create some relief. So it was a disappointing end to the legislative session. The budget passed a couple of things in the healthcare and health insurance sort of realm, but didn't include private insurance in some of the things that they did. So we were left out of the relief, if you will, and then to add insult to injury, the next week, on top of a new tax that they increased and continued, they added, I believe, 9 mandates. Now they haven't all been signed by the governor yet, obviously, and we have work to do in that area. But the legislature just was not having their eye on the prize when it came to health insurance and health care costs. And then finally, the last piece, and I just alluded to it, is also taxes. There's something called the HICRA taxes, Healthcare Reform Act. It went into effect under Governor Pataki and has grown exponentially since then. So this year it's about $7.1 billion on your health insurance, taxes on your health insurance, and taxes on some healthcare stuff, in addition to something called an MCO tax. Each of those add, the HICRA tax adds for an average family somewhere in the neighborhood of depends on where you live geographically in the state, but somewhere between $1,200 and $1,400 a year. It is not nothing.
Wow.
So these are, there's a lot of factors involved.
So you've laid out a lot of information, and you said a couple bad words in there to our members. The first one was mandate, because we share that pain. So that's something that our members share with your members, is that in the legislature and the governor do tend to hand down mandates that make running towns more expensive, running health insurance companies more expensive as well. And so we understand that. We'll dive more into that. Taxes was a second word that our folks don't like to hear, which is interesting because I tell people all the time, if you add up all your taxes that you pay, I am convinced that we are at a tipping point that we are working to pay taxes more than anything else. And that includes, and people are being taxed where they don't even know they're being taxed. We can add up the payroll and the sales tax and the property tax and all, but look at your health insurance premium and how much of that is taxed. We can get into your cell phone bill, your cable bill, you stay at a hotel, your gas. The taxes, they have not been shy about figuring out ways to tax folks, and but this one in particular seems more stealth than most, right? Because you don't get the bill, you don't see the tax breakout that I understand.
Yeah, I think that's really part of the problem, and so there's a few things sort of at play, right? I think that when you get about 20 miles outside of Albany, people have a tendency to not be paying that much attention to what goes on in Albany, despite the fact that it has a significant impact on them. So we pay attention to sort of national news, and we have a tendency to pay attention to sort of hyper-local news. So-and-so won the high school division, and prices just went up at the bakery. And we tend to sort of not pay that much attention to what's going on here. And you hit the nail on the head about the stealthiness of these taxes. So the legislature's loath to pass a tax typically that you're going to see as a New York State tax that the elected official made happen. But what is very easy about healthcare taxes, and mandates for that matter, is that they just are tacked onto your premium. So the HICRA tax I mentioned, like $1,200 to $1,400 a year on your premium, you're not seeing that as a separate line. You are just seeing it as part of your taxes. The MCO tax that was just passed will be 0.35% of your premium. Added on to your premium, you're not going to see it.
Remind me of the MCO. What is that?
The MCO tax was it'll take me a while to get into this. So MCOs are Medicaid plans. So if you tax a Medicaid plan, the federal government ends up paying half of that premium as Medicaid works. So the idea was we're going to get more money out of the federal government, and then we're going to have some extra money come in there. So it was supposed to be heavy on the Medicaid plans, light on the non-Medicaid plans, but the federal government said we're not playing this game anymore. So we tried to copy a model that California did.
Well, that's always a bad idea.
Well, it worked for them for a little while, bringing in a little bit more federal dollars. But the long and the short of it is we now had to modify it, as we had warned a couple of years ago when they were doing this scheme. that there's going to come a day where we're going to sort of leave this to everybody. So the tax is now 0.35% on your premium, and there has been people have been quite open to, we're using that as a placeholder. Greater New York Hospital Association literally said we're going to use that as a starting point, sort of in the next go round. So it's a small tax number wise compared to, say, the HICRA tax that we mentioned. But the mandates that we talked about, they had 12 or 13%, and that's a growing number, obviously, because healthcare costs are going up generally, and then also we're adding more mandates. So figure 12 to 13, another 12 to 13% is a mandate tax, if you will. Now, we're not getting something for that. Obviously, we're adding coverages of certain things, but these are typically things that are not necessarily used by a broad spectrum of people, and so we're socializing these costs sort of across. And I would also not be doing my job if I didn't mention another soon to be coming form of a tax, which is that for many years since the adoption of Obamacare, the ACA, however you want to call it, we have been getting away with a bit of I'm not exactly sure what to call it, but New York's been getting away with something, because we are supposed to be paying for, as a state, benefits, mandates that we issue on Essential Health Plan and these federal funded plans. Anything over the essential health benefits that were originally adopted, we're supposed to be paying for. They've not been calling that check in Washington. And we've been passing mandate after mandate, and every one of these are going to be on New York's tab if the federal government decided to come, if the chickens came home to roost, if you will. Well, they're coming home to roost because the federal government in the last couple of weeks has formalized some new rules, and starting in 2028, we are going to be on the hook for all of those mandates as a state.
Not retro.
Not retro, but forward. If it were retro,
would be in trouble.
Oh boy. And these mandates, as I said, are 12 or 13%. Now, some of them pre-existed, but many of them are newer. So if we figure, even if it's 5%, even if it's a new 5% tick, we're going to be on the hook as a state. And that's going to, obviously, where we know where that's going to come from. It's going to come from you and me in our tax bill. So each and every one of these things, the legislature remains insulated, because you and I don't see that as a tax bill. We see it as a premium. Right. Just as whatever it is. I know people are overwhelmed with utility costs, for instance, another big issue sort of the year. It's sort of the same thing. Yet there are surcharges and taxes and NYSERDA pieces and all of the stuff in your energy bill. But I pay my energy bill, so I'm angry at the energy company, right?
It's the greed, right? The greed of the big corporation.
And that it's an easy out. It is. But if we start to dig a little bit, we see much of this is taxes. Much of this is an invention. I keep pointing because the legislature is literally right there. Yeah. But much of it is an invention of the legislature, and we have given them option after option to not only not pass more mandates and make the matter worse, but also to dig into some reforms that could make the matter better. We're constantly working on it.
We have the same, I think, frustration as far as local government's concerned, because we have a lot of great ideas for reforms that can make local government more affordable too. It's the same thing. Local government is not expensive because local government's inefficient. Local government's is expensive because of the mandates that are placed on them all the time, and without any relief whatsoever. And so you're right, just like your industry sees, our folks see it too, that they come up with these new mandates every year that they just keep throwing on, and it's hurting. But you mentioned that I think healthcare was $7.1 billion in taxes, right? So have you looked at really how much of the premium is driven by taxes and mandates as opposed to what it would be if it was just on utilization? Have you guys have a chance to look at that?
Well, yeah, I mean, you sort of have to work backwards, right? So you figure 12 or 13% on mandates. You figure another, like on a family plan, let's say for sake of argument, $1,300 So you're probably talking about, somewhere in the 25% zone at least, and that's before we even talk about the real cost of healthcare, right? Which is exorbitantly high. So yeah, if we started to back some of the mandates out, if we started to take a look at mandates, and to what you were just saying about local governments, it's sort of a double whammy or even a triple whammy, right? Because taxes go up in our municipalities because they're paying for healthcare, right? And that's going up. What was it, 13% for small groups last year? The rates are gonna the new rates, at least the requested rates, are gonna come out any day now. I would say my expectation is they're not going to be much better than they were last year. Utilization is up on, like we mentioned, GLP-1s and all kinds of other things, and just general costs. So you get the whammy of that cost, which then turns into a local tax, which is your fault, And then you have just all of the other things, the mandates that you mentioned, outside of healthcare that are sort of. But if you are an average New Yorker, with a reasonable or a modest income, and you're a homeowner, no matter how modest that home is, and you're working and you're paying taxes, you're now paying these double-digit increases for your own health insurance, or your employer is. And when your employer is paying double-digit increases, your raises are smaller, your other benefits are smaller. So you're paying for it that way. Then you're paying taxes that are both on the federal level and the local level, paying for Medicaid. So you're paying for health insurance for other folks that way, which, I'm not debating the validity of it or anything. It's a fact. And then you're paying for your school district and your town and your county and all of their employees. A part of your taxes are going up to pay for the health care there. So each one of these things for an average New Yorker is compounded 2 times or 3 times. And to your point, do we work to pay taxes? I mean, I can tell you personally, well, part of it has to do with what we spend. So guilty as charged with the Amazon trucks coming every other minute. But you've got those taxes, your property taxes. I live in a village on top of a town, so I get 3 tax bills locally. And yeah, you're probably deep into July before you're earning for yourself.
Oh, I think, well, I mean, when they look at just property and payroll tax, I think when you add all these, utility you brought up earlier, you add all those up, and I don't know if you ever get through, maybe at the end of the year, maybe in December, you're finally making some money for yourself. It is really a struggle. But towns in particular, I think, have kind of this other dynamic going on that maybe some others aren't. And one of them is, here in the state of New York, you're not allowed to self-insure under 100 employees. Many of our towns, probably two-thirds, if not more, are under 100 employees. They're stuck in the community rate. They're stuck in the dirtiest of the pools, I would say. That's my characterization, not yours. But I would say it doesn't give a town any opportunity to do anything to mitigate its costs. It can't deploy wellness strategies. It can't go out there and try to negotiate. And then worse, to compound that, they don't allow these towns, one of the things we're advocating for is to allow towns to get together in a consortium and have buying power where they can come together as one big group instead of a bunch of little tiny groups. There are 2 ways of doing it. Both are arduous for a small town. They've effectively made it so that it's really not something a town can do, realistically. And so we're trying to say, let's simplify that. Let's just make all the towns come together, let all the towns come together and be able to negotiate better. I think New York is one of the few markets that has this dynamic going on with its towns. Do you see that? Because at the end of the day, we started by talking about what's driving health insurance costs. Do you see that as a way of helping towns lower their costs, or are they still going to face the same types of challenges even in a consortium?
Well, I mean, it's interesting because you're correct, and we changed our definition of small group when the ACA came into effect, and I think 48 states have gone back because the law changed and you were allowed to go back, and we have not. There is this adherence on the state government level to community rating, and they just have not been particularly interested in going a different direction. And I think it impacts small employers across the board, whether they're municipal or private, in a really deteriorous way. And people are constantly looking for way, and that small group market keeps getting smaller because groups are looking for ways out, as you're sort of mentioning. So the more groups that get out, I'm using your words for a minute, the dirtier the pool is, and it gets more difficult and more difficult. So on the one hand, yeah, I think that there's something to be said for looking for new avenues and new ways. I don't want to see these small group pools be decimated to the point of absolute, horror.
You don't
for
have the
small
large
businesses.
numbers you need. Right?
That's right.
Yeah.
So, I sort of look at it like this. I mean, we can play shell games all we want. And we could talk about ERISA and large companies and how they're not subject to any of this stuff. And there's this inequality between small businesses and large businesses in New York because large businesses self-insure and they don't have to deal with any of these rules. And we can sort of shell game. How do we play a game here? How do we play a game here and save a little money? And I spend a lot of time looking more at the fundamentals, looking more at sort of those cost drivers that I'm talking about, looking at gamesmanship on the hospital level. So there was just a reform that we were fighting very hard for in the budget called IDR, Independent Dispute Resolution, which used something called the usual and customary rate. And it would take a long time to sort of explain, but at the end of the day, out-of-network specialists get to charge whatever they want, is really the best way to sort of put it. We were fighting very hard for that to go away. It would save a significant amount of money. I think we proved our point very well because they passed it in the budget, but they left out private insurance. So they passed it for NYSHIP and they passed it for Medicaid, but they left out private insurance. Now, we're not done. We're gonna keep fighting the good fight on this into future years. But those are fundamental changes that we can make. Same thing with mandates and mandate review. There are bills there's a bill out there. Senator Bailey and Assemblyman Weprin, both respective chairs of the insurance committees in their houses, have a bill that would ask, it hasn't gone anywhere, but want DFS to look at each and every one of these mandates, cost-benefit analysis. There are things that we can do. And to quote the Hippocratic Oath, first do no harm, right? So the legislature, the first course of action should be stop passing all these mandates. We're not quite there yet. But yes, I think to answer your question directly, I think that there are things or avenues that towns could take, these sort of consolidated things. I think on a singular town level, it's probably perfectly fine, and you shave off a few points. On sort of a holistic level, on the level of the whole system, I think that unless we fix the cost, we're going to end up collapsing small groups. And there's always going to be municipalities, there's always going to be towns stuck in them, right? Because there's always going to be bureaucratic red tape that someone's going to fail at. Fail is probably too harsh of a word, but something's going to happen. So town X is going to be left in the cold, and then suddenly their health insurance rates are going to go up 25%. So we have to be careful at sort of how we play that particular game. And I think that focusing on sort of all of it together, I mean, you have a job, you have to look out for your constituency, as so do so many others. So I wouldn't blame you for continuing down that road. But fighting to end mandates, fighting to lower the taxes on healthcare, these are things that impact all of us paying premium across the board.
But I just want to make sure I understand it or I heard it correctly. If you're self-insured or you have, under ERISA, you're not subject to the mandates?
No, you're not.
Yeah, so that is a unlevel playing field between the
extremely
small person and the large person.
Yeah, so because federal law trumps state law, and because any company self-insuring falls under ERISA, which is a federal law, they're not subject to any of this stuff. So, when you're whatever, Microsoft, and you're insuring, thousands of people here, your costs are so much lower per person, per family, and you just can't compete. And there's an absurdity to that when you consider that the pizza shop down the road, is getting hammered.
Right.
hammered to try to do the right thing.
Right.
And it's
And
challenging.
there is a risk to self-insurance for even those kind of larger small towns. If you have 150 or 200 even people, you're a couple cancer diagnoses away from having a major problem. The larger company can maybe do it over the large
Yeah,
numbers.
and there's reinsurance, and
Yes.
there's all the
Yes.
things involved, but there's certainly risk involved.
Yeah.
Especially for a municipality, and there have been stories. I mean, I've read them. There have been towns and counties that have been pushed right to the very edge because of what you just sort of alluded to. It's there's always up and downs, up and down sides, I
Right.
should say, to sort of some of these issues. But
So let's do something impossible or maybe dark. Let's get into the minds of a legislator and figure out why do they feel these mandates are not having or maybe they know, or maybe they don't know. I don't know. Why are they passing all these mandates that seemed in their minds to be no consequence financially to these and not causing a problem in the market? Why do they continue to do this without and the taxes, the mandates and the taxes?
So, I've advocated, for Blue Cross and Blue Shield for a handful of years, and before that for small business for many, many years. And I asked myself these kinds of questions over and over and over again. And I sort of came up with the concept that in the legislature, oftentimes folks don't see two sides of a ledger. They see the benefits, they see what we can sort of spend or benefit from, if you will, but they never look at the cost side. It's a blinder. And so if you put yourself in the shoes of a legislator for a moment, someone comes to you, their child has suffered with disease X, and one novel treatment of that disease is not covered by insurance. Many standard are, whatever. So they say to their legislator, we really want our kid to be on this drug. Why isn't it covered? Or on this treatment or on this test? And that legislator is like, I don't know why, but I'll write a bill. And I'm not even suggesting that that's not a legitimate response of a legislator. But what should come next is, let's dig in to see what this is going to cost every New Yorker. That's never done. It's just not done. So when they go through the legislative process, it's all about that benefit side and never about that cost side. Yeah. So I don't think that it is. I don't think it's quite as dark. You sort of use that word. I don't think that it's quite as nefarious as we just want to endlessly socialize cost. It's more of a we want to give people whatever they want.
And that gets, I think, to the heart of the human side of this, right? So the folks listening are typically right now, town employees, supervisors, whatever, and they're dealing with costs. But at the end of the day, any one of us, we get sick or someone in our family gets sick, you just laid it out, you want that, right? You want that. And how do you make those decisions to say, do we say, hey, we should give a scale back, just the basics type of option? Do we let people choose their options, which they'll all choose the cheapest option until they need the more expensive option, and then they'll move there or whatever? So I don't know what the answer is from a human side of it. And technology, we kind of touched on it. I mean, we've talked about some of the new pharmaceuticals and some of the new procedures, but what one of us would not want the best procedure possible to extend our life? And
so it's interesting. So we used to have a very robust choice of plans, as you sort of alluded to, maybe 75 different choices, and we could have, when I was young and I was in school, like, well, what did I need? So you could have a skinny plan, and as you got older, you could get into fatter and fatter plans. We've done away with that in the state, and we don't have that kind of choice. And I think that if we had more choice, we'd have significantly less problems, because we could have people choosing, and there would be a price differential. There's no question about it. But and a benefits differential. But I drive a far nicer car than I did when I was 25 years old. Same goes for everything else. We have the opportunity or the need maybe to expand whatever it is that we buy and that we use. So I think that that's part of that, is to go into a more robust choices. We've stymied ourselves in a lot of different ways, and just, I don't know how one can control human nature, but I think that part and parcel to the question of sort of how do we deal with like these individual needs. I think that we look at things that we're spending money on now that we don't need to be, vis-a-vis the healthcare system. So a bill passed the other night at the end of session that increases what we pay pharmacies for dispensing fees. I believe it goes up to about $10.20 or 30 cents per dispense. A lot of our generic drugs, like a 30-day supply of generic drugs, might cost $2.50. So now it's going to cost $12.50 to get a drug that costs $2.50, because the dispensing fee is 10 plus, if this gets signed, if this bill gets signed. This is, it's a perfect example of, we're going to be spending thousands, millions more on pharmaceuticals for no reason than more money going into pharmacies, which are not typically hurting institutions. And so the question becomes, why? So if we really wanted a discussion about how do we make sure that people get these novel treatments, well, let's stop increasing costs where they're not necessary, and then there might be some more money left over to apply them to where they are necessary. Right. There's a lot of ways to skin that cat, but it all comes down to these mandates. There's no bigger mandate than saying you have to pay X, right? Yeah. And so I think that if we stop doing that, we would have more choices to give folks when it comes to what kind of coverage they're looking for.
I know the carriers over the years have tried to educate the consumer. Let's call them a consumer, health care consumer. There's the EOBs, the explanation of benefits, that come to you, so you see the costs or whatever. But I still think if you're not paying them, you don't care. You're really not looking at those EOBs too seriously. There's been educational campaigns, I think, on trying to change some behavior. I think there's a lot. I have some nurses in my life that I know talk about how the use of the emergency room as primary care has gone through the roof. And I know someone has a fever in the middle, and your kid you bring them, and it's just basically a flu. But these are really driving costs. Yeah. Have you found that any of those efforts, behavior modifications or education, have done anything to curb utilization? Or
it's really difficult. I mean, every time the legislature mandates a new transparency, and I'm talking about health insurance, but transparency is a good thing. I don't mean to suggest it's not. But when they tell a health insurer that you have to mail these explanations of benefit, I have 2 kids, so we get maybe one a week, right, in the house. And at some point, some of these things become a little bit of white noise. And I mean, not to toot my own horn here at all, but I'm a little bit more of a sophisticated thinker when it comes to these issues, because I spend my life doing it. And even it becomes white noise for me. So, my friends who do other things in this world, it doesn't mean much to them. So I think it becomes moot. And I think it's really hard, and you're absolutely right, because if we were better consumers and we cared more about the bottom line and we saw it translate into lower costs for us, I think that would be very, very helpful. I mean, an MRI literally could cost $500 at this place, and you go to the hospital system up the street and it's $1,500. But my copay is the same. So, and I think that as we've moved into people having higher deductibles and stuff, there might be people paying more attention. The more your skin is in the game, I think the more that you do tend to pay attention. I think it's really a difficult. I've been having this conversation for a really long time, and I think in small circles it does help, but it's confusing stuff. So I think really it becomes more of a function of trying to drive down costs generally. I'll give you a really good example. It's another really bad policy that we've been working to change. As hospitals have bought up physician practices, and so you went to your doctor you went to your doctor last year for whatever, and it was, let's say, $200. And now your doctor's office has become part of the hospital system. Same building, same doctor, same nurses, same receptionist, except the sign on the door says hospital, whatever, doctor, whatever. You now get, for the same thing you paid $200 last year, probably went up to $250, plus a $50 facility fee for a hospital facility fee, because hospitals are allowed to charge a facility fee under the law. So we have been saying, why are we allowing this to happen to the doctor's office? That is clearly not a hospital facility, and we're seeing it across the board. So if we could remove just that ridiculous charge, we're talking a lot of money. And if people knew and recognized that, okay, if I go see a doctor here or I get an MRI here, I'm not going to be charged all of this stuff, rather than if I walk into the hospital. The use of an emergency room, there's a cultural thing going on there. There's a, depending on where we are in the state, in a rural area, there might not be that many other options. It's something that obviously we are deeply concerned about, especially now with about 450,000 people leaving, not going to have coverage, although some of them might hopefully find other coverage. It's going to be an increasing problem once again. And it's that weird push and pull of overutilization and underutilization. Those of us that maybe don't go to the doctor as much as we should, primary care wise, and those of us that end up going and doing, primary care at the emergency room. And it's, as I said, that there are so many problems. It is such a vast system with so many issues that's why I spend so much time concentrating what I think honestly are the simplest things. Lowering costs of obvious things that we don't need to be spending money on. All of the other things, we would have a little bit more breathing room. We need to solve them too. Right. I'm not suggesting we don't, but we could create a lot of breathing room if we just dialed back on the mandates, dialed back on these crazy extra expenses that we have no need to do, like facility fees. I could go on forever about some of these things. If you go to a hospital, if you have to have a medication that's a transfusion, for instance, some kind of transfusion, a physician-administered drug, the hospital sells you that drug. Yeah. And their markups are 300%, 400%, 500%. So there's a proposal called white bagging, which would say that no, the hospital can't charge you more than negotiated rates with the pharmacies. Mm-hmm. It's just logic,
right?
But we can't get it done.
You have so many common sense ideas.
It's like you can't sell it, and so we end up paying. You can analogize this with anything, right? So you end up paying $40 for a candy bar. Yeah. That's how this system is working, because there's protections in place for silly things.
This translates into our area as well. There's so many things that we feel like are common sense reforms that will lower taxes immediately on property. One is the public notice mandate. We're not going to get into it because it's not germane to this, but $8 million is spent by towns on this mandate that we have to put these public notices in newspapers, which are, very 19th century thing.
Sure.
But 21st century, we have other tools that are free and more efficient. And so we could eliminate this cost right off the bat. We can't get it done over here. And, it's funny, people ask me all the time, it's so common sense. You have no idea how many opponents common sense has in Albany. And there's a lot of counter folks that are lobbying against these good ideas. There's a print lobby.
That's right.
Never imagine how powerful the print lobby was in the 21st century, but it still is. And they're the ones, putting a kibosh on it. And so I feel your pain because we feel the same ones. And you've talked a lot about the cost structure and what's driving things, a lot of ideas on how to eliminate that. There's one thing I wanted to just touch on before we start wrapping up is, because it's a problem not just in your industry, but I think it's driving, I would imagine, I'm interested in your thoughts on this, driving costs in the health insurance premium, labor shortage, right? I mentioned nurses. The pay for nurses today, doctors, for healthcare workers, for technicians, keep going up and up because there is a bit of a shortage. Sure. Do you see that as a major issue? And if so, what's the answer to that?
Well, I'm not wise enough to sort of go on a sort of holistic approach to it. I can tell you that it's of course true. The UCR issue that I mentioned a little while ago, has us paying specialists, neurologists, folks like that, exorbitant amounts of money for a single procedure, a single surgery. And my thinking on that is typically if we are not wasting money, and I'm not suggesting these people don't deserve to earn a heck of a living. They've worked really hard to get where they are, and they do a vital service. And I don't mean to suggest that, but you don't need $100,000 for a 4-hour surgery, right? 20,000 might do it. And so, if you free up money there, there's always money in these systems left for sort of folks. The nursing shortage is real, and will have an impact. I mean, it will continue. But once again, we had a legislature that was pushing several years ago a nursing ratio bill that was so out of whack with reality that it was going to add $5.5 billion annually to our healthcare costs. So, I think when there's a shortage, you can't control the market. It is what it is. But we have a really bad tendency to manipulate the market on a legislative level, both not just in New York State. I mean, it happens on the federal level too, but in New York State, it really is. So the only thing I can say there is we should be looking for ways to make that better rather than making it more acute. And I think that is what we're doing. But we also have seen some policy shifting on primary care, sort of shifting away from physicians more into sort of other folks, whether they're nurse practitioners or physician assistants or things like that. So they are, there is some balancing that tries to go on to deal with some of these shortages, but it's quite real. And when you go to underserved communities, whether they're in New York City, in corners of the city, or they're in upstate New York in places that we all know and love, it's really hard to attract folks. I'll end it like this because it shows you market forces. But I have a cousin who's a urologist in Pennsylvania, and he sent me a listing for a urologist job in Anchorage, Alaska last week. $1.2 million base pay. Because they can't get a single person there. And that is unfortunately sometimes what it's like in these markets, whether it's nurses or even physicians.
So because two or more people can't have a conversation in 2026 without bringing up the term AI, do you have any idea, and maybe this is something you don't want to even get into or maybe not part of the, but do you believe that AI is going to do anything to try to maybe bring will have an impact on bringing health insurance costs down in the future?
Well, I don't know. I mean, I'm not an AI expert. I have enjoyed using it a little bit here and there, but what I do think is that where you can replace certain jobs, even, and it's sort of a dirty word to say it, but where there's certain things that some of us do that would be more easily applied, and that would probably save some cost, and also it's very effective in reviewing files and things like that. So I'm sure that it is and it will be utilized for those purposes going forward. But what we've seen in the legislature is when technology advances, especially in realms like insurance that are hyper-regulated, there ends up being pieces of legislation introduced to stymie that from happening, whether it's to preserve certain jobs, or whether it is because they think that AI is using things that it shouldn't be using, whether it's our credit scores or, you've read these articles, right? Sometimes it's race involved, or, there's racially charged issues involved. So, I think there's an endless push and pull there. I think ultimately AI is going to change how we do business in every area. And I would think that healthcare for sure, and health insurance for sure will have an impact in the future. And the more streamlined we can be, the better. Let me give you one more example. It's not AI, but it highlights something that I find amazing in the state of New York. We've been advocating for the sharing of electronic health records between hospitals and health plans for several years, and the hospital groups have been pushing against it. And so they have it in Connecticut, they have it in California. It has lowered the rejections by I think it was 22% off the hook for those not enough medical information denials. It has streamlined it, has made it so much faster. So we're talking, we currently share them in the state of New York unless there's an agreement between plans and hospitals, and we do have several hospitals that are in those agreements. We share that stuff by fax still. And you look at how long it's taking the legislature to even say, no, that's crazy. So AI, I think, is 3, 4, 10 steps beyond that. So we're stuck in faxes now, but we'll get there.
Sounds like the public print mandate.
I
We're
mean,
stuck in the 19th century here.
Super similar. Super similar.
Curiosity, I meant to ask you earlier, 48 states went back to the lower 50, right?
Yeah.
The 50 definition set 100 employees for commuting. Which two? New York did not.
New York and one that I can't remember
Probably
right now.
California is what I was going
No,
to bet.
I don't think it is actually.
Right.
It was a.
I'll
I just
look it up,
can't
'cause
remember.
I'm
Yeah,
curious
yeah.
why
And we may even be the only outlier at this point.
Probably,
Yeah,
I would
it's
imagine.
possible
That's
that we
not,
are. Yeah.
That's not surprising. The last thing I'll bring up, because it's unique to, maybe it's not unique specifically, but one of the issues, the dynamics of health insurance for towns, and I don't expect you to maybe even comment on this if you're not willing or interested in talking about this, but for us, what's painful very often is the Taylor Act, right? So we are stuck with rich benefits. And when you look at the history of the benefits in towns in particular, there was a time, maybe the 80s or so, where salaries were the expensive thing, but benefits were very cheap. And so towns gave away benefits as a way of keeping their budget low. And so they've got themselves into this own jam. Well, fast forward, now the market's changed, and that's really kind of flipped. I was a supervisor for a bit, and I saw health insurance premiums rivaling salaries or now surpassing them in some areas. And so now they're stuck in this thing where they can't change these. They get into collective bargaining, but everything stays the same. If the union does nothing, everything stays the same. And that's a difficult situation to negotiate from. So certainly not an issue that you necessarily deal with, but for my members, I think it's something that they have to start thinking about. When they get to the bargaining table, they have to start thinking about the real cost of what they're giving away in some of these health insurance benefits.
Sure.
And not always have that Cadillac, as they tend to call it. But it's a real problem, I think, in New York specifically. There's no strategy for the town to get out of what they're in right now.
Right. I mean, as I said, it's not an area that I have any expertise in at all. I can tell you this. I mean, we work with a host of different folks and different groups, whether it's municipal groups like Association of Towns, or we work with something called the Local Business Relief Coalition, which almost entirely they're the same issues, right? We're all sort of in this, and we have labor partners that we've worked on specific issues with in the same, and I think everybody's eye is on the same prize, which is bringing down the cost of healthcare. So if you take away the pressure of that cost, then that issue of the Taylor Act is probably not as severe. And that's it. It's almost too easy of an answer, right? Because it's very hard to bring down those costs. But I think that is, I think that we all need, we're all working together on several of these issues, and I super appreciate the support from the Association of Towns and from others, and each and every town in New York State. I'm more than happy to speak to anyone about these issues and sort of dive right in. And we all have dual tracks, right? We're working on these things together, and then we all have sort of issues where they're sort of specific to our needs. So I don't besmirch anyone running a town in the state of New York for trying very hard to sort of change those underlying laws. But at the same time, I would say equal amount of attention and effort to trying to control these costs. Because if we can do that, the other is less of an issue. And if you can accomplish both, then God bless you.
I agree, and I think as a town organization, the towns may have had a blind spot to the mandates and the taxes and all that comes into that. So that's something new that we'll be focusing on, I'm sure, as we go forward. Yeah. Lev, this has been a very engaging conversation, very interesting. We can go on and on about health insurance, and there's so, as you mentioned, it's so complex and so big and so many different pieces to it. Is there anything we didn't touch on that you wanted to touch on? I think you threw a lot of great ideas out.
Yeah, I mean, there's a lot out there, and there's a lot to talk about, and we could go on forever, or we could talk about football if you'd like. Happy to do that too.
Go Bills.
Go Bills. But no, I think we've covered a lot of things. I mean, what I really want to leave folks with is, I am happy to be a resource anytime, and walk and talk through any of these things. And we keep pushing and we keep fighting to lower premiums. The more partners we have, the more vocal partners we have, I think is endlessly important. And let's not forget that every town in New York has elected officials. And we talk about the legislature, and we can debate sometimes whether they're doing the right thing or not. But individual legislators obviously do care about their local communities. I would say make these things known to whoever it is. If they're in the majority, if they're in the minority, don't let up. And and get as specific as you can.
Yep.
I think that always helps. And listen, progress is not always fast. Sometimes it's slow, and we're fighting against a lot of vested interests. So we'll keep fighting.
It is an interesting paradigm. The individual legislator is very invested in the community, very interested, want to do the right thing, the best thing for the community. But as a group, somehow it's a very interesting end result that comes out as a group.
Every time.
Yeah, every time. But I want to thank you for being here. I want to thank you for enlightening us on this. Again, all you folks that have been watching or listening, make sure you hit like, share, and subscribe. Let's get this message out to all of our members across the entire state. And if you have any questions, make sure you reach out to us at nytowns.org, which is our website. You can click on there and send us comments, questions, suggestions for future shows. And Lev, again, thank you for being here. And go Bills. And let's see what we can do about getting those premiums down.
Very good. Thank you for having me, Chris.